Detail, so well organized for everybody involved, right down to the snow and the Super Bowl. So my talk is going to be maximizing meniscus repair. And it's important when you do think about meniscus repair to select the right tear. The next talk by Jack Bird is going to be really about patient selection. But of course, we know the slide by Steve Arnowski with proximity to the rim, 3 millimeters from the rim where it's vascular, and vertical orientation like the MRI shows. In that, if you have a concomitant ACL, a patient under 40, and patients able to accommodate the post-op restrictions, you'd think about repairing the meniscus, especially with that prior MRI I just showed. The hard thing comes in when you have that situation in a young athlete who is potentially about to get a scholarship and can't afford the time off to do the appropriate rehab, and they ask you to take the meniscus. So the first thing I'll do is, after deciding to think about a meniscus repair, is assess the vascularity. Doing that with no tourniquet, we can see in this case that this would be one situation where I really strongly think about repairing the meniscus. Now, there are going to be several options available to you right now. A year from now, we're going to have even more options as the industry is going to be having more and more fixators available that are better than what we have today. Right now, we have sutures out there as well as fixators. And in my job, I think, in showing how to maximize meniscus repairs, I'm going to go through some of the salient features of a few of them, the ones that I like. I still do inside out. It's a single lumen. It minimizes scuffing the cartilage. Of course, anytime you introduce a cannula, the possibility of a cartilage scuff is there. It's the most popular. It's readily available. When you talk to our colleagues in Europe and South America and third world countries, this is all they do. And the bottom slide shows you the versatility of this technique where you can do vertical, horizontal, and oblique sutures. And definitely you want to approach from the contralateral portal, as the slide on the right shows. That way you miss the neurovascular structures. Now, one thing I want to make clear is, see if I get the pointer to work. You want to remember when you're doing a medial side, you want to remember the saphenous nerve. The saphenous nerve branches above the joint line, here's the joint line, into the infrapatellar branch of the saphenous nerve, which we get when we harvest our grafts for ACLs, and the sartorial branch. And one way to make sure you know where it is if you transilluminate, you will see the vein. You don't see the nerve. But you can know that right behind, right posterior to the vein, is going to be the nerve. The nerve coming out right behind the sartorius, right superficial to the gracilis. Now, the inside-out results have been studies. We consider that the gold standard, but there haven't been that many studies out there. 1 year, 5 months, some longer, but the failure rates have been anywhere from 10 to 12%, 19%. And since there are no level 1 studies, one wonders why this really is the gold standard. Now, one of my very favorite techniques that I'm going to spend a little bit of time on is the outside-in technique, and I use this for anterior 2/3. The reason you want to do it anterior 2/3 and not the posterior third is because you want to approach the tear perpendicularly, and it's very difficult to do that in the posterior 1/3. But in the anterior 2/3, it's a very, very versatile approach. It's easy. There are no posterior incisions that are needed like inside out. No intra-articular cannulas to scuff the cartilage. No needle sticks to you or your assistant as you're retrieving the needles. In fact, you don't even need an assistant. All you do is make a couple extra arthroscopy portal, and it's very cosmetic. Way it's done, 2 spinal needles, one is curved. One, you insert this rigid metal loop. Once you snare it, the other spinal needle, you push through a PDS suture and then extract the needle. You have the suture caught by the loop, and you're done. All you do is tie a knot the regular way. There are no arthroscopic knots needed. In this model, I had to put in a horizontal suture, but obviously you can see you can put in vertical sutures as well. It's a very simple and very, very quick technique. Outside-in results are very good. They're as good in the literature as the inside-out. One can see in the studies that I'm quoting a 14 to 26% failure rate. A lot of these studies are older studies. A lot of the failures were in ACL-deficient knees. Mulberry knots were used instead of the technique I showed, and sometimes they were in the posterior third. Another intriguing way for all inside is the meniscal viper made by Arthrex. The slide on the right is showing how it's sort of a reverse scorpion. You put the device over the meniscus, insert the needle, which will grab the suture. You need to do this in posterior third tears. I find it best in the lateral third of the meniscus. You need to do this through a cannula, and then you'll tie a racking half hitch. It is difficult to do in tight knees. There are no studies, but I do this technique when I find the right tear, usually the posterior third of the lateral meniscus. Now, our approach to meniscus repairs changed dramatically in 1996 when fixators were introduced, and it made all of us into meniscus repair surgeons. There were no accessory incisions. It was painless to the patient. It was simple and quick and easy, and we all know we want to repair instead of resecting, so the amount of meniscus repair suddenly shot up in 1996. And why not? The initial Arrow studies were great. The Arrow was the first fixator on the market, and the failure rates, looking at those failure rates, they're actually better than the failure rates that I showed you before for the sutures. Failure rates down at 5%, 9%, and that was at 2-year follow-up. And just look at the last one. Dudich had a 9% failure rate at 2 years. And on this next slide, when he carried it out to 6.5 years, he had a 29% failure rate, which is what I showed at 4.5 years. One can see the broken arrow, and on the right, the scuffing of the articular cartilage. And that's what led us to say we no longer use the Arrow. Fixators evolved, and they're evolving today, and there's new stuff coming on the market that's very exciting. But right now, there are 2 second-generation suture-based fixators that are available, the Rapid Lock from Mitek and the Fast Fix from Smith & Nephew. For the first time, you can fix peripheral tears to the capsule, and you can adjust compression, and none of these are possible with first-generation fixators. The Rapid Lock comes with a backstop anchor. The backstop anchor is mounted on the needle. There are 3 needles, 0, 12, and 27 degrees. Our surgery center just stocks the 12 degree. We find that the most versatile. And then below is the top pad anchor, which can be in either resorbable or non-absorbable, and it's cinched down with this pre-tied sliding knot right behind it with a number 2 braided suture. It's very simple. It's mounted on a gun. The trigger is deployed after you're through the meniscus, and right there you can see the deployment of the backstop anchor. And it's a very simple way to get compression. You'll notice that I'm doing a push-pull. It's an equal push, equal pull, and then you can adjust the compression. You get a dimpling of the meniscus, and then with the same device you can cut it. Very rapid. Hopefully this slide will show. Can you click on that, please? So here's one of my live surgeries. I'm inserting the device. This is with no editing yet. I'm doing a push-pull. This is with a resorbable top hat. Getting it down, you'll notice the dimpling of the meniscus, and it gives you excellent fixation. The Rapid Lock results have been very good. 9 to 12% failure rates at 2.5 and 3 years. No complications reported except for 1 case of scoring of the condyle by Alan Barber, 1 infection. The Fast Fix has 2 anchors, 5 millimeters in size. They come with a 0 non-absorbable suture. They're changing the suture to a max braid. And it's available with 3 needle configurations, plus 22, 0, and minus 22. We basically stock in our surgery center just the plus 22. I don't really find much use for the 0. The minus 22 can be used to go under the meniscus, which is unique for this fixator. This is also quite simple. You simply pass the needle through the meniscus, and the anchor is caught. You deploy the second one through the meniscus. Now note on the right, this is not a push-pull to deploy it. It's mostly a pull. You have to do a strict pull, and then you get your final tensioning with a push-pull before you cinch it down and then cut the suture. You can do horizontal mattress, vertical mattress. In these pictures, I'm showing a vertical mattress. You deploy the first one on the upper left. Here, this went into the capsule. You bring the second implant down into position and then go through the tear, across the tear, and then cinch it down. The reason I'm showing it like this is to emphasize one pearl, and that's that the knot always follows the second implant, always. And that would be my preferred technique here, because I want the knot. I want to be able to compress the tissue with the knot. I don't want the meniscus to be lifting up if I had the knot on the other side. So remember that your knot always follows the second implant. Fast fix results are quite good, comparable to everything we've shown. 10 to 21% failure rate, no complications. But beware, it's not so simple. One study by Miller published in July of 2007 in a cadaver study showed that the fast fix was within 3 millimeters of the artery in the AP and lateral radiographs in 43% of the specimens. So beware the posterior horn of the lateral meniscus. It may encourage you to put the stopper they have on the fast T-fix. Here's another slide showing where you can penetrate, even with the limiter, you can penetrate the iliotibial tract, you can penetrate the skin. So beware. Another factor out there is, if many of you do own surgery centers, hospitals aren't so keenly aware of costs, but these are expensive. And for you to put in 3 stitches, your cost to the surgery center is almost $900 for the fast fix, and for the rapid lock, it's going to be $553. So if you're only going to get $1,500 for the case, your partners may not like you if you're using a lot of these. While if you use suture, it's a lot cheaper. On the other hand, you are saving a lot of time. So it's a mixed bag what you do. I do know I've given this talk, similar talk before, and a lot of my colleagues from other countries tell me that they really can't use the fixators because the patients have to buy them and bring them to surgery, and they can't afford to do it. So the final pearls, we're almost done. This is really what I do to maximize meniscus repair. I find it's really important to get an anatomic reduction just like you would with a fracture. And sometimes it's difficult to hold that reduction, so I'll put in a K-wire from outside in and hold it just like I would a K-wire for a fracture. I want to make sure that my repair is stable, just like you would if you had a fracture. You'd want to make sure it was stable. So what I'll do is I'll put in all my fixators and sutures, take the scope out, and range the knee pretty vigorously. Then I'll put the scope back in and test it. And a few times I've been surprised where I've lost fixation and have to refix it. Hybrid fixation is very important, something I do all the time. Once I decide what to do, I don't necessarily stick to one technique. I will use second generation fixators posteriorly. I'll use outside-in sutures anteriorly. And I mix and match all the time. I try to be perpendicular to a tear just like you would with an interfragmentary screw coming through the contralateral portal. I want no threads or barbs crossing the fracture site. You wouldn't want a screw crossing the fracture. So no first generation fixators in our surgery center. You want to ensure a good blood supply. I trephinate, I rasp the synovium. And I think the future is going to be something like bone graft equivalent, which would be platelets. We want to be able to improve. Why do we still have 15 to 20% failure rates? And I think the future may be in biology. I'm starting to toy with platelet-rich plasma, and I think that this may be part of the answer for us to improve that 20% failure rate. Thank you.